I just have a few minutes this afternoon to speak with you guys about ERAS and my experience with ERAS and in its use in complex hernias. But just to give you a little historical perspective, ventral hernias remain very common. We do about 350,000 annually in the United States at a cost of about $3 billion. Historically, these have had relatively high morbidity rates of especially wound complications in the 20 to 30% range. Length of stay historically was quite long for very complex reconstructions with patients who needed component separations to get their abdominal wall back in order. We looked at our own ventral hernia repairs in patients who didn't have component separations back in 2016, and even the medium-sized ventral hernias were still staying about 2.1 days. But this field has continued to evolve. The open techniques that we use to fix hernias have changed. We now have posterior component separations that don't require as many skin flaps and improves wound morbidity. We have really good minimally invasive techniques that continue to evolve every single year, from laparoscopy to now complex abdominal wall reconstruction with the robot, which allows us to do component separations with no big skin incision. And then coupling onto these new techniques, bringing in the principles of enhanced recovery after surgery, we can really begin to marry all the best of all of these worlds together to give our patients the best outcomes. So these are just a few of the options that hernia surgeons have. We have traditional open techniques, laparoscopic techniques, and now robotic techniques which mimic the old open techniques minus the big incisions. And as promised, these are some of the problems we deal with. They're complex problems of the abdominal wall that are not easily fixed and can be prone to recurrences if not taken care of well. So we really get one good chance to give these really challenging hernias a good fix the first time. These people did well. So when I see these patients in the office, I really want to get them in the best shape as possible going into surgery. And a lot of this will overlap with what you just heard Dr. Wasson discuss. But the discussion begins in that preoperative visit with the management of expectations. She has developed, Dr. Wasson's developed a very good video in her department that gives every patient the same information going into surgery. That's something we're working to do in the hernia department as well. But we also try to address modifiable risk factors. We call this prehabilitation. We discuss preoperative hydration and carbohydrate loading. We discuss with the patient